Okay, I'm Dr. Amr Shehab. I'm an SHO in Egypt Air Hospital in Egypt, one of the tertiary hospitals in Egypt. Today, I'm going to talk about an interesting topic and a very crucial one that we usually face in any kind of hospital, which is acute coronary syndrome. I will start sharing the screen now. Just a moment. Window and wait a minute. Okay. Is it visible right now?
Yeah, it is. It is.
The PowerPoint, right?
No, we still can see the Microsoft Teams.
Okay. So can you give me a second?
Yeah, sure.
How about now?
Yeah, we can see it now.
Okay, so first thing first, what is acute coronary syndrome? So acute coronary syndrome is a syndrome that occurs as a result of decreased blood flow in the coronary arteries, impairing the function of the heart muscle. It presents with ischemic chest pain. That is the similarity that we will talk about right now, that it has three subtypes. So the similar thing between the subtype that we will talk about is that all have ischemic chest pain. Okay, so the first subtype is called the ST segment elevation myocardial infarction. And the second one is the non-ST segment elevation myocardial infarction. And the third one is the unstable angina. So as far as for now, we have three subtypes that all present with chest pain. So that's an overview, three subtypes, and the common between them is the chest pain. So it's very crucial now to get more deeper into the chest pain and see what is specifically meant by ischemic chest pain. Okay, so the classic symptom of acute coronary syndrome is substernal chest pain. It's often described by the patient as like a crushing or like an elephant on the chest of the patient, or like pressure-like feeling. It's usually radiating to the jaw or left arm. That is the usual presentation of this kind of pain. However, in some cases like diabetic patients or females or older age patients, it might be presenting with some vague symptoms like difficulty breathing, lightheadedness, isolated jaw or left arm pain, or maybe nausea and epigastric pain, or excessive sweating, or even weakness. So we see now that it might present with the symptom that most of us know, that is related to the heart, the heart chest pain, or some vague symptoms in this kind of cases like diabetes, female gender, and the older age patients. Okay, now to understand the different subtypes of acute coronary syndrome, we need to recall two important points. What is the ST segment that we mentioned before, and the rest of ECG waves and segments and intervals, and also the cardiac territories. Okay, so let's start with the ECG waves and the ST segment. So what is the ST segment and what does it represent? The ST segment is the flat isoelectric section of the ECG between the end of the S wave and the beginning of the T wave. And it represents the interval between the ventricular depolarization and repolarization. Okay, so this is the ECG. We have P wave, we have QRS complex, and we have the T wave. Okay, and we have some segments and some intervals. The segments is the distance. It's measured in the lining, the joining between a wave and other. While the interval is usually a timing. If this timing is increased, we say that there is prolonged PR interval. If we have the QT interval, for example, we only describe it if it's abnormal as if it's prolonged or not. Okay, so that's the difference between an interval and a segment. Okay, and a segment is just the joining between a wave and other wave. Okay, so let's continue. We now talked about the different wave that we have. And regarding the intervals, we have, as I've told you, the PR interval and also the QT interval. And regarding the segments, we have PR segment and the ST segment that is important today in the acute coronary syndrome topic. Okay, so the ST segment is like in this picture, between the end of the S wave and the beginning of the T wave. Okay, and the end of the S wave is usually described as the J point. Okay, so let's see the cardiac territories or the contiguous leads that we have to look for the ST segment elevation or depression in it. Okay, so this is the cardiac territories. We have anterior, lateral, and inferior cardiac territories. The anterior can be described as anteroseptal. Okay, let's dive in each cardiac territory alone. Let's start with the anterior, for example, anteroseptal cardiac territory. Okay, the anterior cardiac territory takes from V1 till V4. The V1 and V2 usually represent the septum of the heart, and V3 and V4 represent the anterior wall of the heart. And from V1 to V4 is called the anteroseptal, and it's usually takes blood supply from the LAD, left anterior descending artery. So if there is any myocardial infarction in the anterior wall, it will be occluding in the anterior wall, meaning that it will be in the anterior leads. It will indicate that there is occlusion in the left anterior descending artery. Okay, and the next one is the lateral leads. The lateral leads usually takes from lead 1 and AVL and V5 and V6. Okay, so if there is, we have seen any like ST segment elevation in this kind of leads, it usually indicates that there is infarction in the lateral wall of the heart, which indicates that there is obstruction in the left circumflex artery, which is a branch of the left anterior descending artery. Okay, now jumping to the inferior leads. The inferior leads takes from lead 2, lead 3, and AVF. And if there is any abnormality in this kind of leads, it usually denotes that there is infarction in the inferior wall, and meaning that there is occlusion in the RCA, which is the right coronary artery. Now let's talk about STEMI. It's on your computer now, right?
Yeah,
the
yeah.
slide that says now, yeah, okay. So we now have knew the what is ST segment, and now we have known the cardiac territories. Okay. Now let's talk about what is the first subtype of ACS, which is the STEMI. Okay, STEMI, it presents with a clinical picture of ischemic chest pain that we now have knew what is ischemic chest pain, with an ECG showing ST segment elevation of more than 1 to 2 millimeters. So what is 1 to 2 millimeters on the ECG? It's what the 1 millimeter on the ECG is one small square box. So if the ST is elevated more than 1 to 2 small square boxes in 2 contiguous leads on the ECG with an ischemic chest pain, so we are highly suspecting here an ST segment elevated myocardial infarction. And there is also other criteria to consider a STEMI and manage it as a STEMI, which is something called LBB, but it has to be new LBB here. Okay, and we will discuss in a few moments what is LBB, which is left bundle branch block. Okay, so we can have an example right now of an ECG and see where is if there's any ST segment elevation and where is the ST segment elevation in this ECG, to be able to know what subtype of acute coronary syndrome we are talking about in this kind of slide. So if we started with looking at lead 1, we will see that there is elevation in lead 1 in the ST segment for 1.5 small square boxes, and in lead 2 there is ST depression for 3 small square boxes. In lead 3 there is also 1, 2, 3. There is also 3 small square boxes ST depression, and in V1 there is ST elevation very high, even the S segment ended even higher than the isoelectric line. Okay, so it's elevated about also 3 small square boxes. And we have also V2 showing ST elevation, V3 as well, V4 showing also ST elevation, whereas V5 appears to be normal and V6 appears to be elevated as well. So from this kind of ECG, Dr. Mohsen, what you are suspecting here? What kind of ST elevation is it like affecting which kind of wall in the heart, anterior, lateral, or?
So I can see an ST elevation in lead 1, an ST depression in 2 and 3, AVL is elevated. So there is a lateral affection in the limb blades. And then V1, V2, V3, anteroceptals, so it's probably anterolateral ischemia, isn't it?
Yeah, it's anterolateral ischemia, and that's very good. Yeah, and regarding the management, we will talk about in a few moments. But for now, I would like to also discuss about the left bundle branch block. The left bundle branch block is the second type of the ST segment elevation, or it's regarded as ST segment elevated myocardial infarction, because we manage LBB and ST segment elevated myocardial infarction the same. Okay, so if we have found a new LBB, we usually manage it as a STEMI. Okay, so the first question, what is LBB? It's blockage of the left bundle branch that deliver electrical impulses to the left side of the heart to contract. Okay, so how that happen? If the patient developed ischemic chest pain with a new LBB on the ECG, that is definitely a myocardial infarction that have led to the affection of the left bundle, and it's managed as STEMI cases. But how we can identify LBB on the ECG? Okay, so that is the LBB ECG finding. The most important findings, of course, LBB have different criteria on the ECG, but the most important ones on an ECG is finding this kind of finding, which some call it M and W. The M is because of the M-shaped QRS complex in V6, and the W is for the W-shaped QRS complex at V1. To be more scientific and to know why the W is W and why the M is M, okay, so we have to understand that in V1 here, we have an S wave. This one, this deep wave is an S wave, okay, and this is something called dominant S wave. And in V6, what is M shaped here is of course the QRS complex, but this is the R wave. Okay, and it's broad and notched because of the delay of the electrical impulse to be delivered to the left side, whereas on the right side there is no blockage of the electrical impulse, so it was delivered normally. Okay, so the first peak in V6 was the right-sided electrical impulse, and the second peak in the V6 is the electrical impulse that was delivered to the left side of the heart and was delayed because of the blockage of the left bundle. Everything clear so far?
Yeah, it's clear for me.
And the other slide that I've just changed.
Yeah, it's changing now. It's changing.
Okay,
Good.
perfect. So now we have known the STEMI with its two cases, the ST elevation in specific cardiac territories and the LBB, which we have now known how to identify it on the ECG. Okay, now we can talk about the non-STEMI, which is the second subtype of the ACS. Okay, what is non-STEMI? It presents with a clinical picture also, ischemic chest pain, and an ECG showing territorial ST depression, or maybe T-wave inversion, or even normal sinus rhythm. Okay, so it can be on the ECG, it can be anything other than the ST elevation, might be ST depression, might be T-wave inversion, but it have to be honest, it have to be territorial, meaning to have the territory that we have talked about, the cardiac territory, either to have it on the anterior leads, the lateral leads, the inferior leads. We cannot accept T-wave inversion in like lead 1 and that's all. It have to be in lead 1 and in AVL, and V5 and V6 to consider it, of course, 2 contiguous leads only, to consider it as a non-STEMI. Okay, so it have to be territorial. So if we had ischemic chest pain with an ECG showing territorial ST depression or T-wave inversion, or even normal sinus rhythm with elevated cardiac enzyme, and that is the most important actually for the non-STEMI, elevated cardiac enzymes, and the cardiac enzymes of course include troponin, CK, and CKMB. That's highly indicative for non-STEMI. Okay, let's take an example of the non-STEMI. This ECG shows what, Dr. Mustafa? Dr. Mustafa, are you with us?
Yes.
Can you tell me what do you see in this ECG?
It shows like T-wave inversion, I think. What do you mean exactly?
Yeah. In lead what?
Say again.
Again, please.
You say again, what did you ask? Sorry.
Yeah, okay. So in which leads did you see the T-wave inversion? What kind of leads, and what kind of wall that you feel that there might be ischemia in?
So let's try to do the arrow, like lead 2, lead 3, V5, V6, and so it's strip 2. So 2, 3, 5, and 6. V5 and V6.
Okay, and what walls that you suspect that there might be ischemia in it from this leads that you're seeing?
I don't get your question. Like which artery you mean?
Yeah, it's easier if we you have told me which walls of the heart might be having the ischemia, or if you can tell me what kind of arteries might be affected. The lateral, okay, because of V5 and V6, and
yes.
Do you suspect any kind of walls?
Anterolateral.
Anterolateral. Okay. You are very close to the right answer, but yeah, V5, V6. So you suspected that the lateral wall might be affected, but lead 2 and lead 3 is associated with the inferior wall. So in this case, there is ischemia to the inferior wall and also to the lateral wall as well. Okay.
Okay.
Okay. I don't know why that happened. Okay. So the next subtype of acute coronary syndrome is the unstable angina. Okay, so what is the unstable angina and how we can differentiate it from the stable one? Dr. Mohsen, did the slides change?
Yeah, I did change. Yeah, I think it's working fine now.
Yeah, okay, perfect. So unstable angina, it presents with a clinical picture of ischemic chest pain that we have talked about, and ECG showing normal sinus rhythm or insignificant changes. Okay, so the ECG will be normal in this case, but with also a negative cardiac enzyme. That is the difference between the unstable angina and the non-STEMI. Okay, but if there's everything is normal here, how we can differentiate it from the stable angina? Unstable angina is differentiated from the stable angina by the kind of pain, how the patient describes the pain. If there is increased frequency of the pain, like it occurs like twice a day, and it used to occur like once daily when the patient is climbing the stairs to his home, okay? And now it's occurring like twice daily or 3 times daily. So the frequency increase. If the duration of the pain in the stable angina is usually 15 minutes, if it increased to be 30 minutes, okay, so there is increase of duration. The exacerbating and relieving factor, and that's an important thing here, because stable angina exacerbated by effort, which is moderate physical exertion, for example, and relieved with rest. If the pain decreased and if the pain does not decrease with rest anymore, the patient rests and there is no improvement in the pain, and the pain now occurs exacerbated with minimal effort or even starts at rest, So we're talking here about unstable angina, not stable angina. And that's important. Why that? Because stable angina is not a subtype of ACS and is not life-threatening. It's something managed with medications only and some investigation just to ensure that there is nothing serious other than the stable angina. But the unstable angina is an ACS. It have specific management that is dramatically different than stable angina. Okay, so now we have talked about unstable angina. Now we have talked about the 3 subtypes of acute coronary syndrome, and what is the similar thing about it is the chest pain and how we can differentiate between each type with the ECG and the cardiac enzymes. Now we can talk about the management, how we can manage acute coronary syndrome. The proper management of acute coronary syndrome depends on its type. The management of a STEMI differs than that of a non-STEMI or unstable angina. And actually, I found that the best source to know the management of the STEMI and non-STEMI and management of the ACS was the visual summaries of the NICE guidelines. It was perfect. The STEMI, in this visual summary, we will discuss the STEMI management, okay? I want to, oops, okay. Okay, so the STEMI management, how we can manage a case of STEMI that was presented with ischemic chest pain, and we have done an ECG showing ST elevation, showing ST elevation or a new LBB, okay, and we have diagnosed it as a STEMI. Of course, we will consult the cardiologist, but how the cardiologist will function, how the cardiologist will manage this case. First thing first is to offer 300 milligram of aspirin, loading dose of aspirin as soon as possible, and continue aspirin indefinitely unless it was contraindicated. Which cases might be contraindicated to use aspirin is the hypersensitivity of aspirin, as for example, allergy to aspirin. It's noted here because it was in the past used as routinely, is to do not offer routine GPs, which is the glycoprotein inhibitors or fibrinolytic drugs before arrival at the cath lab if primary PCI was planned. Okay, so we should not use any GPIs or fibrinolytic drugs. And immediately assess eligibility for reperfusion therapy. How we can assess the eligibility? We have to be excluding the age, the ethnicity, the sex, level of consciousness. Okay, when we are assessing the eligibility for reperfusion therapy. If eligible, offer reperfusion therapy as soon as possible. Otherwise, offer medical management. Okay, so now we will discuss the reperfusion therapies that we have to manage this kind of cases. We have 2 kinds of reperfusion therapies. We have the angiography with follow-on primary PCI, and we have the fibrinolysis. So in which cases we should use angiography with PCI and which case we should use fibrinolysis? We should use angiography with PCI if the patient is presenting in 12 hours of the symptoms, and PCI can be delivered within 120 minutes, which is 2 hours. And consider if presenting more than 12 hours after symptoms and continuing myocardial ischemia or cardiogenic shock, meaning that if the patient presented within 12 hours, maybe it's better to be within 120 minutes, we will choose to use prime PCI. And if the patient presented after this window, but still having ECG showing ST elevation, myocardial ischemia and ST elevation, or the patient was having cardiogenic shock, we will still offer him or her primary PCI. Okay, and the new guidelines now put privilege on the radial or preference in the radial axis over the femoral axis. Okay, because it has lower time to stay for the patient to stay at the hospital and less time for monitoring the patient as well. Okay, so now we have talked about the which patient we should choose PCI for. We can now talk about the drugs therapy for the primary PCI, which I would like to divide it in which drugs we should use before starting the PCI and which drugs that we should use during the PCI. Before the PCI start, we should start with prasugrel with aspirin if not already taking oral anticoagulant. Okay, so prasugrel with aspirin is the best choice if the patient do not have high bleeding risk. is not taking oral anticoagulant, prasugrel, okay? But we use clopidogrel with aspirin if the patient is on oral anticoagulant, or in the illustrated guidelines, it said that if the patient has high bleeding risk, because prasugrel causes more incidence of bleeding than clopidogrel, okay? So that is the drugs, dual antiplatelet drugs that we should give before the PCI. So during the PCI, what kind of medication should we give the patient while on the table of the PCI? We offer unfractionated heparin with bailout GPI, which is the glycoprotein inhibitor for radial access. So this kind of medication is divided or categorized whether we will use radial access or femoral access. If we use radial access, so the preference is for the unfractionated heparin with the bailout with the glycoprotein inhibitor. Bailout here means I think supporting. If the unfractionated heparin was not sufficient, we can use as a supporting drug the glycoprotein inhibitor. And if we were on a femoral axis, we will use bivalirudin with bailout also glycoprotein inhibitors. So the bivalirudin is for the femoral axis, and the unfractionated heparin if we chose radial axis. And this is an important thing here, this note, for people ages 75 years and over, think about whether risk of bleeding with prasugrel outweighs its effectiveness. If so, offer ticagrelor or clopidogrel as alternatives. So if there is high bleeding risk, again, you should not use prasugrel. You should use ticagrelor or clopidogrel. And in the illustrated guidelines, again, clopidogrel was the best for the high bleeding risk. Okay, the ticagrelor have higher bleeding risk than clopido, but of course, prasugrel have the highest bleeding risk. Okay, so now we have talked about the drugs during the PCI and before the PCI. Some like advanced information about the stenting that we can use. Nowadays, the normal mechanical stenting is outdated at all, and all the guidelines in preference of the something called drug-eluting stents, which when is put in place, the stents start to effuse or elute drugs to prevent any thrombosis after the stent, and that helps a lot on the re-thrombosis incidence after the PCI. Okay, so drug-eluting stents are the best now. Also, is something also very advanced here. The guidelines was talking about the whether we should do complete revascularization, meaning that if the patient have coronary artery disease, we should fix all of the coronary arteries, or we should do something called culprit revascularization, which we open the diseased vessels only. Okay, but it's something logical here, because the guideline says if there is no cardiogenic shock, okay, so you have all the time that you can have, so you can fix all the multi-vessels. You do complete revascularization. However, if there is cardiogenic shock in the patient, so you don't have time, and there is no it's not a safe case here. You might cause problems to the patient. So you should do something called culprit fixation or culprit revascularization, in which you fix only the diseased artery that is causing the infarction. Okay, all clear now?
Yeah.
All clear, Dr. Mohsen?
Yeah, it's clear.
Perfect. Okay, so this is regarding the angiography with follow-on primary PCI. This is the most preferred way of management or way of reperfusion therapy per the guidelines, and is the most used nowadays. However, there is fibrinolysis, which was indicated only in the guidelines on very specific cases, which, as I have written here, as it's written here, should be offered if presenting in 12 hours of symptoms and PCI is not possible in 120 minutes. In 2 hours. So if the patient presented in within the 12-hour margin, and we are not able, that there is no suitable hospital to offer a PCI within 120 minutes, we should start the fibrinolysis. The fibrinolysis should be given with an antithrombin at the same time, and we should schedule an ECG after 60 minutes or 90 minutes after the fibrinolysis. And why that? Because if you have done the ECG 60 to 90 minutes after the fibrinolysis, and the ECG showed also ST elevation. Still there is ST elevation. There is still myocardial ischemia. This patient should be offered primary PCI again if possible. Okay. So the ECG after 60 to 90 minutes is very crucial here because it will direct us whether we need a follow-on primary PCI or angiography, or we should settle with the fibrinolysis only. So if you gave fibrinolysis, you should give with it antithrombin at the same time, and also give your dual antiplatelet therapy, which is ticagrelor with aspirin, unless again high bleeding risk. If there is high bleeding risk, we should consider clopidogrel as an alternative to the ticagrelor. Okay. So this is regarding the medication, the dual antiplatelet that we should give with the fibrinolysis. Some notice written here also. Do not repeat fibrinolysis. Offer immediate angiography with follow-on PCI if indicated by ECG. This is the ECG that was done 6 to 90 minutes. Seek specialist advice for recurrent myocardial ischemia. And offer angiography with follow-on PCI if appropriate. Consider angiography during the same admission if stable after successful fibrinolysis. So if the fibrinolysis was not successful after the ECG, after the 90 minutes, we should do PCI. If the fibrinolysis was successful, we should do angiography just to ensure that the vessels are clear, there is no thrombus in any part of the vessel, or there is no occlusion. Okay, so we should consider angiography during the same admission if stable after successful fibrinolysis. And also, that's very important, if the patient underwent a PCI or underwent the route of the fibrinolysis, we should not discharge any patient having STEMI from the hospital before we assess the left ventricular function by an echocardiogram. That's also something new. It was added in 2020 in the NICE guidelines. Okay, so this regarding the reperfusion therapy. We can now talk about the medical management. Okay, and the medical management, we only go for the medical management if we cannot do reperfusion therapy. So what is the medical management? In the medical management, we offer ticagrelor with aspirin unless high bleeding risk. Again, I consider clopidogrel with aspirin or aspirin alone for high bleeding risk. And offer cardiology assessment for cardiologists to do examining the patient. Also do investigation if appropriate. Again, assess the left ventricular function before discharging the patient, and starting something called cardiac rehabilitation and sacral prevention, which is a very important topic also that we will talk in a few minutes. Okay, so that's the STEMI patient. Let's now talk about the non-STEMI patient or the unstable angina. Okay. The management of the non-STEMI or unstable patient start with the same management of the STEMI. We start with aspirin. We give 300 milligram loading dose of aspirin and continue aspirin indefinitely unless contraindicated, like what? Like allergy. So is the start of the management is the same. But the initial antithrombin therapy here is something different and unique for the non-STEMI. We offer fondaparinux, which is low molecular weight heparin, unless high bleeding risk or immediate angiography. So we should not offer fondaparinux if there is high bleeding or immediate angiography, meaning that we will do angiography with a PCI or without PCI immediately. So we should not give fondaparinux because it will increase the bleeding risk while doing the puncture for the angiography. Okay. Think about choice and dose of antithrombin if high bleeding risk. We should consider the advancing of age, bleeding complication, renal impairment, low body weight. Consider unfractionated heparin with dose adjusted to clotting function if creatinine above 265 micromole per liter. So yeah, unfractionated heparin is better if the creatinine was high than the fondaparinux. Okay. Then after that, now we have given the aspirin, and whether or not we have given the fondaparinux will be dependent on whether or not we are going for angiography right now or not. Okay, and now we should do something called GRACE score. What is GRACE score? Is a score that predicts the 6-month mortality and risk of cardiovascular events include in the risk assessment, clinical history, the physical examination, resting 12-lead ECG, and blood tests like troponin and the total creatinine, glucose, hemoglobin, balance possible benefits of treatment against bleeding risk. So this is the gray score. So it will like guide us what should we do next after the aspirin and the fondaparinux. Okay, if this gray score was intermediate or high risk, meaning that the predicted 6-month mortality was higher than 3%, we should do something. And if it was low risk, meaning that the predicted 6-month mortality was less than or equal 3 months, we should have a different kind of route than what should we do in the immediate or high risk. So what should we do? How we can manage a case of risk score with more than 3%? First, we should offer immediate angiography if clinical condition was unstable. Otherwise, consider angiography with follow-on PCI if indicated within 72 hours if no contraindication, such as comorbidity or active bleeding, meaning that if the patient was unstable, you should go directly for the angiography. If the patient was stable and he's just having intermediate or high risk, that's all. The patient is stable. So you will go also for angiography and PCI, but it will be within 72 hours. Okay, not an immediate angiography like the one for the STEMI and this one for the non-STEMI unstable with the intermediate or high risk. Okay, so this is the cases that we will go for an angiography directly if it was intermediate or high risk. If no separate indication for oral anticoagulant, offer prasugrel or ticagrelor with aspirin. If a person has a separate indication for oral anticoagulant, offer clopidogrel with aspirin. Only give prasugrel once PCI intended. Okay, so the patient was not taking oral anticoagulant, you can offer prasu or ticagrelor with aspirin. If the person has separate indication for oral anticoagulant, you offer clopidogrel with aspirin. Only give prasugrel only once PCI is intended. So that's the important thing here. It was illustrated further in the longer type of the guidelines that if the patient is already on anticoagulant, you will give clopidogrel with aspirin. If the patient had the PCI, that is not illustrated quite briefly. Sorry, it was not illustrated appropriately here in this visual summary, but if the patient was on anticoagulant, you give clopidogrel with aspirin only if the patient had a PCI. But if the patient had no PCI and is on anticoagulant, you give what? You give aspirin only, either aspirin only with no clopidogrel, or you can consult the cardiologist for alternatives of the clopidogrel because this patient is on oral anticoagulants. Okay, so only give the next note is only give prasugrel once PCI is intended, and offer systemic unfractionated heparin in catheter laboratory if having PCI. Offer a drug-eluting stent if stenting indicated. Again, this point indicates that the drug-eluting stents is more preferable nowadays in the NICE guidelines. And the point before that is during the PCI, what kind of anticoagulant we should give is the unfractionated heparin. Okay. It didn't specify here whether the unfractionated heparin should be preferred only in the radial axis at that the STEMI or not. It's open-ended here. You can use unfractionated heparin whether you are having a femoral or an radial axis. For people ages 75 and over, think about whether bleeding risk with prasugrel outweighs its effectiveness, because again, prasugrel have caused many cases of bleeding. That's why in the patient of having an age of over 75 years, they already have high bleeding risk because they have fragility in the blood vessels. So you should consider whether prasugrel is appropriate here in this case or not. Okay. If follow-on PCI not done, consider angiography findings, comorbidities, risks, and benefit when discussing management strategy with the interventional cardiologist, cardiac surgeon, and the patient. Okay, so if no of the above cases, the patient was not unstable, meaning that the patient is stable, and he has no intermediate or high risk, you should discuss with the interventional cardiologist, cardiac surgeon, and the patient, and the patient's preference whether or not we should do something else, like interventional meaning of treatment or not. And after that, you should assess again the left ventricular function for non-STEMI. Consider assessing for unstable also. So it's definitely indicated to assess the left ventricular function in the non-STEMI case, but it can be considered only in the unstable. It can be only considered, not like definitely indicated. Okay, that's of course before discharging the patient. Okay, and again after that, you should start cardiac rehabilitation and sacral prevention that we'll talk about in a minute. Okay, so all of that, if the patient was having a gray score of more than 3%. So what if the patient had a gray score of equal or less than 3%? We should here consider conservative management without angiography, but be aware that some younger people may benefit from early angiography and offer ticagrelor with aspirin unless high bleeding risk. Consider clopidogrel with aspirin or aspirin alone for high bleeding risk. Consider ischemia testing before discharge. So if the patient had low risk, less than or equal 3%, you should do conservative management alone without any angiography. But of course, it's not it's definite. You should consider ischemia testing before discharge, because if the ischemia in the next box, it says consider angiography with follow-on PCI indicate if the ischemia develops or shown on testing, the testing that you have just done, like the stress ECG, like also the technetium type of nuclear imaging with stress, also with the patient running on the treadmill. It gives us idea if there is ischemia or not. If the patient was positive on the ischemia testing, here we should consider angiography, even if the patient was low risk on the gray score. Okay, after we have finished the management of the patient, of the low risk patient, we should assess the left ventricular function if it was non-STEMI, and also consider assessing for unstable angina. After all of that, the patient is ready for discharge. We should have a plan for cardiac rehabilitation and the secondary prevention. So what is the cardiac rehabilitation and sacral prevention that we were saying a lot about? Okay, so the cardiac rehabilitation, it starts before the hospital discharge. An assessment appointment should take place in 10 days of discharge. Okay, so it's something that should be started before discharge, and we should have assessment appointment again after 10 days of discharge. The cardiac rehabilitation program include several things like physical activity adapted to clinical condition and ability, and also lifestyle advices, including advice on driving, flying, and sex, stress management, health education, all of that. Lifestyle changes like healthy eating, Mediterranean diet is proved to have more benefit to the heart. That include, of course, more bread, fruits, vegetables, fish, and products based on plant oils. Alcohol, low risk drinking, not more than 14 units a week, because more than 14 units a week have been evidenced to increase the risk for developing cardiac incidents. Okay, regular physical activity, 20 to 30 minutes a day, to point of slight breathlessness, increase duration and intensity gradually while gaining fitness, and stopping smoking, reaching and maintaining a healthy weight. Okay. So that's regarding the cardiac rehabilitation. All clear regarding the cardiac rehabilitation, Mustafa? Mustafa, are you with us?
I think the connection with Mustafa's dropped, probably. You can't see him on the list.
Okay.
Yeah.
Okay.
But
so
yeah, it was clear to you? Yeah.
Okay, perfect. Now regarding the secondary prevention, drug therapy for secondary prevention. So what kind of drugs we can give to the patient to prevent this from developing again? First, the most popular drug for cardiologists is the ACE inhibitor, and the patient could continue indefinitely, and ARB if the patient is intolerant to the ACE. What kind of intolerance that the patient can develop from the ACE inhibitors? Most probably is the cough that we usually develop with the ACE inhibitors. That's why the between brackets paragraph, the between brackets sentence is important here, because the patient developed like the cough from the ACE, you can switch with the ARBs. Okay, and what other medications? It includes also the dual antiplatelet therapy like aspirin, plus second antiplatelet for 12 months. Continued therapy starts in acute stage unless a separate indication for anticoagulation. Okay, so you should continue the therapy started in acute stage unless separate indication for anticoagulation. Then you should stop this because it will be a high risk for bleeding. Beta blockers, consider diltiazem or verapamil if beta blockers contraindicated, which are CCBs, which are calcium channel blockers. So if the beta blockers contraindicated, you should consider diltiazem or verapamil. And no, of course, pulmonary congestion or reduced left ventricular ejection fraction. Okay, because some kinds of CCBs are contraindicated because contraindicated in the low ventricular ejection fractions because it can worsen the ejection fraction. Okay, continue beta blocker indefinitely if reduced left ventricular ejection fraction. Okay, so if there is reduced ejection fraction, you should continue on the beta blocker indefinitely. Otherwise, consider continuing for at least 12 months. Okay, and also you should consider adding for the patient a statin because that's also will help to decreasing the atherosclerosis rate to the patient's coronary blood vessels. Okay, we have also an important box here, which is say the drug titration, how we can titrate the ACE, how we can titrate the beta blockers. That's an important thing. ACE inhibitor should be titrated upwards with monitoring every 12 to 24 hours if the patient is in the hospital, and complete titration in 4 to 6 weeks of hospital discharge. So if you are in a hospital, it's better to titrate the ACE in the hospital. That's the first choice, and the frequency of titration should be between 12 to 24 hours. If you cannot do that and the patient have to be discharged, it's okay. You can complete your titration in 4 to 6 weeks of hospital discharge. The most important thing before starting ACE and after starting the ACE and during the titration, you should do renal function and serum electrolytes. The most important electrolyte when we talk about the ACE is of course the potassium, because ACE inhibitors causes significant hyperkalemia. So if the patient already has hyperkalemia, you will cause arrhythmias. You will cause life-threatening arrhythmias actually. Okay. So, and blood pressure before starting an ACE inhibitor because it decreases the blood pressure, of course, or ARBs, and after 1 to 2 weeks. So you should do this renal function or all this laboratory investigation before starting the ACE, and also after 1 to 2 weeks, just to ensure everything is okay. Beta blockers, you should titrate to the maximum tolerated or targeted dose. Let's talk now about the antiplatelets when it comes to regard the secondary prevention. Antiplatelets with an indication for anticoagulation. Do not routinely offer prasugrel or ticagrelor with an anticoagulant needed for a separate indication. If the patient is already, this is the part that I was talking about in previously. If the patient was already on anticoagulation, continue and offer clopidogrel to replace the pras or the ticagrelor for up to 12 months if the person has PCI, and consider continuing aspirin for up to 12 months. Clopidogrel if aspirin contraindicated, if no PCI and not a high bleeding risk. So if the patient was already on an anticoagulant and I've done PCI for my patient, and what secondary prevention, what antiplatelets I will give this patient, the patient had PCI and is on anticoagulants, so I will prescribe clopidogrel. Okay, and if the patient also was in another patient was having or taking oral anticoagulant, but he didn't had any PCIs, so I should prescribe for this patient aspirin. Okay, and both should be prescribed for up to 12 months. Okay. 4. New indication for anticoagulation, offer anticoagulant and clopidogrel to replace the pras or ticagrelor for up to 12 months if the person has had PCI. Aspirin again for up to 12 months if no PCI. Okay. So this regarding the management of the acute coronary syndrome, how we can manage the STEMI, how we can manage also with the STEMI is the new LBB, the left bundle branch block, and how we can manage non-STEMI and unstable angina, and what what does we mean? What do we mean when we say cardiac rehabilitation, and what do we mean when we say secondary prevention? What kind of drugs we are talking regarding the secondary prevention, and how we can titrate these drugs, and what kind of laboratory investigation we should do before starting these medications and during the course of these medications. Okay, that's all regarding the acute coronary syndrome, and this is the reference that I've used to cover my topic of the acute coronary syndrome, the definition, the ST segment definition, and the left bundle branch block, the ECG criteria, and also the management of the STEMI, non-STEMI, and unstable angina, and the secondary prevention of ACS, which I used the NICE guidelines, the updated NICE guidelines, to cover these topics. Thank you so much.
Thank you so much, Dr. Amr, for this very informative and interesting and hot topic, as you mentioned in the beginning. So
yeah,
I'm sure that every one of us have faced a patient with a chest pain at any point of his daily practice, either in the ED or clinic or even in GP practice. So yeah, thank you for all this refreshing the guidelines with us, which have it's as usual we'll push to cardiologists, but it's nice to have an idea of what the cardiologist would think about.
Yeah, thank you so much.
I'll just give the chance for our colleagues if anybody has any question or a comment.
Yeah, Dr. Khalid.
I'm not sure. It looks like Mustafa has a connection problem and he dropped out. Dr. Khalid, do you have any questions? Dr. Khalid is a pulmonologist, so I'm sure he wouldn't be interested in these details. Okay, thank you again, Dr. Amr. Very pleased to have you with us today, and
thank you.
We hope to have more of these nice sessions and discussions in the futures, inshallah.
Yeah, thank you so much.
And yeah, the feedback will I'll prepare the feedback form and share it on the group hopefully today, inshallah.
Okay, perfect.
All right. Thank you everybody for being with us this evening, and see you again next Friday, inshallah.
Thank you so much.
Thank you very much. Assalamu alaikum.
Excellent.